Welcome to This Week in Pulmonary. This week we're covering 7 notable papers spanning critical care management, phenotyping in chronic lung disease, and advances in specialized pulmonary care. Let's dive in. First, in critical care, we have 2 papers that address personalizing the early management of sepsis. A perennial question in the emergency department and ICU is the optimal approach to initial resuscitation in septic shock, early vasopressors with fluid restriction, or a more liberal fluid strategy. The ARISE Fluids trial randomized over 960 patients to one of these 2 strategies. The primary outcome was days alive and out of the hospital at day 90. The investigators found no difference between the groups, with a median of 76 days in both. In the first 24 hours, the vasopressor group received about 1.1 liters less intravenous fluid. While survival outcomes were similar, there was a striking difference in adverse events. Pulmonary edema occurred in only 0.6% of patients in the fluid-restricted group, compared to 5.0% in the liberal fluids group. This suggests that while both strategies may be equivalent for survival, a more restrictive fluid approach may be safer for the lungs. Beyond initial resuscitation, choosing the right antibiotic is paramount. A fascinating post-hoc analysis in the American Journal of Respiratory and Critical Care Medicine revisited data from the ACORN randomized trial, which compared cefepime to piperacillin-tazobactam. While the original trial found no difference in mortality, this new analysis explored whether the baseline white blood cell count modified the treatment effect. The authors found a significant interaction. In patients with a white blood cell count of 16,000 or higher, treatment with piperacillin-tazobactam was associated with significantly lower odds of 28-day mortality compared to cefepime. This suggests that in patients with a more pronounced inflammatory response, piperacillin-tazobactam may be the superior agent. While this finding needs to be confirmed in prospective studies, it points toward a future where a simple, readily available biomarker could guide empiric antibiotic selection in sepsis. Moving from the ICU to chronic disease, a major theme this week is the push to better define patient subgroups and treatment goals to guide therapy. In COPD, a paper in the American Journal of Respiratory and Critical Care Medicine proposes disease stability as a new achievable treatment target. This was defined as a composite endpoint of no moderate or severe exacerbations and no worsening in CAT score (ORF-EV1) from baseline. In post-hoc analysis of major clinical trials, single inhaler triple therapy was more likely to achieve this state than dual therapy, and adding mepolizumab to triple therapy also increased the rate of stability. The clinical relevance is significant. Patients who achieved stability at 28 weeks had a 45% reduction in the risk of subsequent exacerbations and a 51% reduction in the risk of all-cause mortality. This provides strong evidence for aiming for a state of low disease activity in COPD, which predicts meaningful long-term benefits. This idea of identifying important phenotypes is also central to interstitial lung disease, as highlighted in a state-of-the-art review from the European Respiratory Journal on Progressive Pulmonary Fibrosis, or PPF. This review synthesizes our understanding of PPF, a condition where various fibrosing ILDs, not just IPF, take on an IPF-like progressive course. This phenotype is characterized by worsening respiratory symptoms, decline in lung function, and early mortality. The review underscores the importance of early identification of PPF, as this is the trigger to initiate antifibrotic therapy, such as nintedanib, which has been shown to halve the rate of FVC decline. And in a similar vein for pulmonary hypertension, another paper in the American Journal of Respiratory and Critical Care Medicine focuses on identifying a high-risk subgroup that is often misdiagnosed. Researchers aim to develop a clinical score to distinguish classic group 1 PAH from the more aggressive phenotype of PAH with features of venous or capillary involvement, formerly known as PVOD or PCH. Using 7 clinical variables, including DLCO 6-minute walk desaturation, PaO2, smoking history, and specific CT findings like septal line thickening, they created a PVOD likelihood score. When tested in 3 international cohorts of transplant-eligible patients, the score performed exceptionally well, with an area under the ROC curve of 0.97. Such a tool could be invaluable in clinical practice for the early identification of these high-risk patients, helping to expedite their referral for lung transplantation. Finally, we look at a complex post-transplant complication and a call for better research standards to guide future care. A comprehensive review in Nature Reviews Disease Primers details the current understanding of chronic graft versus host disease, or CGVHD, a major cause of non-relapse mortality after allogeneic hematopoietic cell transplantation. The review covers the complex immune dysregulation involving B cells, T cells, and fibrosis. While glucocorticoids are first line, about half of patients become steroid refractory, necessitating second-line agents that target specific pathways, such as ibrutinib, ruxolitinib, belumosudil, and axatilimab. The paper stresses the need for multidisciplinary care to manage the morbid manifestations, particularly in the lungs and skin. To improve the evidence base for treating severe lung infections, a new European Respiratory Society statement. The task force, which included patients and relatives, addressed the problem of heterogeneous and often irrelevant outcomes used in past studies, which has made comparing trial results difficult. Through a rigorous Delphi process and consensus meetings, they defined a standardized set of outcomes that should be reported in all future trials of community-acquired and nosocomial pneumonia. The core sets include outcomes like all-cause mortality, treatment success or failure, serious adverse events, and readmissions, providing a framework to ensure future research is more consistent, comparable, and patient-centered. If you only have time for one paper this week, make it the post-hoc analysis of the ACORN trial in the American Journal of Respiratory and Critical Care Medicine. It suggests that a simple white blood cell count could guide the choice between cefepime and piperacillin-tazobactam in sepsis, potentially improving mortality in patients with high inflammatory states. Here are the key takeaways from this week in Pulmonary. First, in early septic shock, a fluid-restricted strategy with early vasopressors does not change 90-day survival compared to a more liberal fluid strategy, but it does significantly reduce the risk of pulmonary edema. Second, for septic patients needing anti-pseudomonal coverage, a high white blood cell count, specifically above 16,000, may signal a survival benefit with piperacillin-tazobactam over cefepime, though this requires prospective confirmation. Third, in COPD disease stability, a composite of no exacerbations and stable symptoms and lung function is an achievable treatment target with intensive therapy and predicts better long-term survival and lower exacerbation risk. Fourth, for patients with fibrosing ILD, be vigilant for the progressive pulmonary fibrosis phenotype, as its identification is a key indication for initiating antifibrotic therapy like nintedanib. And finally, in newly diagnosed pulmonary arterial hypertension, a new clinical score using variables like DLCO oxygen saturation and CT findings can help identify the high-risk PVOD-PCH subtype, which requires expedited referral for lung transplantation. That's your roundup for this week in Pulmonary. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.